Have you thought about your cardiovascular health in perimenopause or menopause? Have you noticed that your blood pressure is suddenly high, or someone suggesting that you get started on a statin? Or is it not even on your mind at all? If not, or all of the above, you got to listen in today because we all need to be paying attention to our cardiovascular health. Today I have Dr. Lisa Larkin, who studied at Yale and University of Chicago. She's a board-certified internal medicine and women's health expert. She's been practicing in Cincinnati, Ohio for over 30 years, and she's the founder and president of Concierge Medicine of Cincinnati, a multi-specialty primary care and women's health practice with 3 locations in Cincinnati where she continues to practice. She's the founder of Ms. Medicine and the CEO, which is a national women's health company committed to advancing high-quality women's health care. She's a renowned expert in menopause management and sexual medicine, and she is one of the top docs. She's one of my favorite people. I'm so excited for you to learn from her today. Thank you, everybody, for joining into our Womanity. I am thrilled to have Dr. Lisa Larkin here. She is a longtime friend, a colleague. I've met through the menopause world, actually, I think through Dr. Cheryl Kingsburg.
Yes.
And I've been so fortunate to be in the same state as you in Ohio. So, I have sent you patients, you have sent me patients. And when I think of complicated cardiovascular issues for women and they're trying to decide what to do with their health, you are my go-to person. I've heard you give amazing lectures on cardiovascular risk assessment, trying to figure out during menopause whether someone wants to start hormones or should start hormones or not, and how to appropriately assess their cardiovascular health and risk. So that's why I want you on for today.
Thank you so much for having me. I'm so excited to be here. And I think this is a really important conversation and really love what you're doing with the podcast because there's a lot of noise out there and a lot of variability in what women are hearing. And I think that this is such an important topic.
Thank you. And I feel like cardiovascular health, maybe it's not as sexy as, like facial plastic surgery, like some of the other topics, but it is the number one killer of women nationwide is cardiovascular disease. And Absolutely. It is one of those silent killers. And so it's why I feel like it's so important to shed light on it. So I wanted to ask you, in your practice, in your experience, what do you see happening for women with their cardiovascular health? What are the changes that you see during perimenopause and menopause?
All right. Well, let me first step back and say, one of the big issues, I think, with healthcare delivery and what's happened in the women's health space is that the time of life when I believe that women would benefit from having the best care is the time when women right now are getting the least amount of medical care because, and I'm talking about the ages of really like 40 to 55 or 40 to 60, this is the time when women are pretty healthy still. They're generally done childbearing. They don't have as many points of contact with their OBGYNs anymore. They're getting their pap smears at it's not annually anymore for most women. They're kind of up to date on their mammograms. They're entering the perimenopause transition and things are starting to change, but they're busy with their careers. They're busy with their families, and they just don't have access or need for many points of contact. And yet this is the time when things are changing so significantly for women in terms of all kinds of things, cardiovascular health really playing into this, and women don't get enough care. And what we know across the board is that the time that we can influence, right, when you're going to develop cardiovascular disease, how you are going to live, when you are going to die, this whole concept of healthy aging and a longer health span, not just a lifespan, really has to take into consideration that we need to address cardiovascular risk factors and start early, because the goal with everything that I want to do in being an internist is prevention, right? So I'm all about preventing breast cancer, but I'm also all about preventing cardiovascular disease and preventing osteoporosis. And it has to start at midlife. And we haven't done a good job across our system, our national healthcare system, of having trained people and giving women the opportunity and the time to have these visits. But long answer to say, the perimenopause is a time when we know that women's cardiovascular risk is increasing very quickly. All kinds of things are happening metabolically, related to lipids, related to their vascular health, that goes along with hormonal changes, right? These are all happening. And what we know is that we need to do better at risk assessing women and identifying those women that are at the highest risk so that we can intervene aggressively. Because what we know today, unfortunately, their risk assessment is not done as regularly. People don't think about cardiovascular disease in a 45-year-old woman the way they do in a man. We aren't treating them as aggressively for their hypertension or their hyperlipidemia. And we're missing opportunities to, again, do better prevention. And we've got to do a better job.
You're giving me chills because not only am I passionate about this topic, but it's also personal. So I'll be 41 next month, and it took me a year and a half to get into my primary care physician, not because of them, because of me, right?
Right.
I
And
had
I mean, you're the classic person, right?
I
You are
am.
someone who's at the peak of your career. You're busy with
Yes,
your young family. Like you
exactly.
feel pretty well day to day. You're keeping up with your
Yep,
mammogram and you're exercising. And like, again, like you're not getting the care that I want you to have because now's
exactly.
the time for you to prevent disease.
I had to cancel my appointment twice because, I was stuck in the operating room. So I wasn't out in time to get to her office. And then I ended up finding someone new who was great. But I saw her 4 months ago and I still haven't done the blood work that she ordered for me.
Okay.
And I come from a place of privilege, right? I have
Yes.
resources, I have support, I work at a hospital where there's a lab.
And that's really true. I just 2 weeks ago went into a company in Cincinnati, Gorilla Glue, and did education for actually the line workers, factory workers, all of these things, multiple shifts. And what you realize again, right, is again, if it's hard for you to get
Right.
to care, you are taking a whole nother group of individuals who also are really struggling to have access and care. And like we are really not doing enough for our midlife women to ensure everything we should be doing for prevention of disease.
Right. And you said I'm exercising, but that's actually not true. Maybe I exercise once.
Okay. I'm going to shake my finger at you.
Exactly. Maybe once a week when I really would love to be
I
working
know
out,
you're so
more
busy with
often.
your young children, though. I
But
mean,
this is the
it's
reality, right? And this is the time where, I'm that demographic, unfortunately, where we need to be doing that preventive work.
all right.
So,
Well, get your labs. We'll come back and have another podcast where we review your own labs and we talk about your cardiovascular risk and what we should be doing now.
exactly. That would be amazing. But tell me more. So, this is also when we see cholesterol levels
Yes.
increasing, like
Right.
all of that
So
stuff
all of
starts to
the things
increase.
start to happen. And I really, and you're in this space too, this, women and men are very different and they
Yeah.
age differently, right?
Yeah.
So men age really very gradually across the lifespan and women have periods of time related to hormonal changes that happen very abruptly, right? Very different biology, physiology, that there are changes related to aging at midlife that happen abruptly with women, right? So we see this spike in metabolic changes, development of insulin resistance, development of prediabetes, LDL cholesterol goes up. We know that after menopause, HDL is not protective, those in the same way it is premenopausally. Women gain abdominal fat and visceral fat, which is also happening around the heart, right? Which is a marker of cardiovascular risk. And all of these things are happening relatively quickly. So this is the time when, every single week in practice, I have a woman who comes in who said, last year my lipids were great. And this year you're telling me my cholesterol's a little higher and now my blood pressure's borderline.
So
And
you
like,
really see it from year to year. As soon
yes,
as a
like
year.
it's a relatively significant change. And they've just gained 3 or 5 pounds. And now their hemoglobin A1C has gone from 5.2 to 5.5. And like, you just can see that these things are happening. And this is the time. And believe me, just like you, Rachel, I can preach it really well. And I don't have a perfect diet or a perfect lifestyle either. But it's really talking about small incremental changes and trying to give women tips and information and ideas about what's happening so that they can actually do everything when it comes to thinking about cardiovascular disease risk reduction. And the good news is the same things that I talk to them about for cardiovascular risk reduction are the same things that I talk to them about for breast cancer risk reduction, which is what women in their 40s are more worried about than heart disease.
Right.
But again,
True.
we know that the majority of women, but they're the same things, right? It's healthy diet, it's exercising, it's maintaining ideal body weight, it's not drinking too much alcohol. And it's really looking at all of these metabolic factors very carefully and intentionally over your year to year visit. The problem is, again, women have few points of contact. And lots of times, someone like you, 45-year-old, right? She only sees her primary care doctor when she has a sinus infection and she's in and out in 2 minutes. And none of this other stuff is really even thought about or addressed. And she's busy and just happy to get that antibiotic and get her sinus infection treated.
See, if they had like a little station at the end of the Target, like cashier lane, where I could just like throw my arm in, have my blood pressure checked, have my blood drawn, I would be so compliant.
Well, I don't know if you personally, so now we're in practice, we're using it looks like a glucose monitor, but we have something called a BioBeat, a blood
Cool.
pressure monitor. You wear it for 24 hours. I get a great report of
Oh,
your
that's so
continuous
cool.
blood pressure, kind of like a continuous glucose monitor. And these are kind of the things, the technology and the wearables now that are kind of helping us, I think, collect data on individuals like you who may be busy, who come in and have that borderline blood pressure, who say to me, oh, it's just white coat hypertension. I was stressed. I didn't sleep well last night. I got stuck in traffic. It's like nothing. And then we don't see you for 18 months. And again, we know that we're letting women run higher blood pressures and not being as aggressive as we should be. And controlling hypertension is critical for preventing cardiovascular disease, right? So these subtle elevations we really want to know about.
That's such a good point. And we were talking about this a little bit earlier. For women who have gone through pregnancies and had hypertension during pregnancy or diabetes during pregnancy or preeclampsia, we know that they are then at higher risk for hypertension later.
Right. And so this is such important work that is finally being done really in the last 5 or 10 years, looking at differences in cardiovascular disease in women and men. And what we know is that they're different diseases, right? Like we never really thought about looking at cardiovascular disease, right? So diseases that occur in women and men for decades, centuries, we've assumed that they just have to be the same. Women are just smaller men. But what we know is that women do have smaller coronary vessels. But what we now understand too is that they form plaque differently, right? They form plaque more diffusely along their smaller coronary arteries. So that's one of the reasons that their symptoms tend to be different, right? Like in medical school, you and I were taught that the classic anginal chest pain is, the elephant sitting on your chest and pressure associated with shortness of breath. Women often have much more diffuse symptoms because the disease is different. The development of atherosclerosis in women is different in terms of men. And then when we think about, again, what are the risk factors for it, right? It turns out that there's actually some very sex-specific risk factors that we haven't really considered before, right? So there are these pregnancy-related adverse pregnancy outcomes that definitely influence cardiovascular risk. And this message is finally getting out there that we're starting to think that when we assess risk factors in men and women, we have to think about it a little bit differently. The problem right now is that our standard risk assessment tools that we use, so what internists use still mostly is the ASCVD risk score in practice. We calculate that, but those don't take into consideration any of the adverse pregnancy outcomes like preeclampsia or hypertension with pregnancy or gestational diabetes. Now, there are, from the American Heart Association, guidelines now that are telling us as internists that we have to remember that if someone has intermediate ASCVD risk score, but has some of these other novel risk factors, that will put them at higher risk. And we need to be much more aggressive about thinking about screening them. And there's lots of amazing cardiologists. Martha Gulati is one of them. I just heard an excellent presentation you just did about this topic, right? Again, which we know that the ASCVD risk score can underestimate risk pretty significantly in younger women, especially because we're not taking into consideration some of these other risk factors like inflammatory conditions and these adverse pregnancy outcomes. And so again, like we have to be doing a better job at taking a good medical history of women at midlife so that we can be much more proactive about helping them do the things that they need to do or should be doing to prevent these diseases from happening.
How much do you think weight has to do with it all? Because also I'm thinking, okay, at this stage of your life, if you're like me, you've had your kids, you have not gotten back to your pre-pregnancy weight, and then you're hitting perimenopause, and then it's harder to lose weight, right? I feel like this is also a really important stage of trying to get like weight control.
Yeah, 100% agree. So, I mean, and this data as well as I do, right, is that midlife women gain weight. It's about 1.5, 1.7 pounds per year for 5 to 7 years as they go across the transition, right? So the vast majority of women do have weight gain with or without menopausal hormone therapy. It's disproportionately visceral fat, right? All of us, and I'm way beyond this now, right? But, postmenopausal women, if you look, right, we all have back fat and arm fat and places of fat that we didn't used to have it, right? Fat distribution really changes. The risky fat distribution is the abdominal visceral fat distribution. And so I will tell you in practice now, and lots of women are doing this, there's lots of ways to actually have a better understanding of your body composition. And the truth is, I mean, I'll tell you, me personally, right? Like my weight is not high, but my body fat distribution. So, I mean, like I've done my own body composition now, and I'm skinny fat really is what you would call me, right? My percent fatty fat, my visceral fat is actually higher than it should be, right? For sure. And I have pre-diabetes and right. So just, this is why BMI.
I think of you as like the most active, healthy.
I'm
like,
I'm a good exerciser, but I still, my physiology, I'm aging for sure like everybody else. And it just goes I mean, this is, Dr. Angela Fitch, who's a good friend and colleague in the obesity medicine world. I mean, she talks all the time about the fact that body mass index is not perfect and that body composition is actually much more important to think about. And so for me, right, my BMI is not high, but my body composition actually isn't good. And I've been really working on that in terms of trying to shift and increase my lean muscle mass and reduce my visceral fat. And I can tell you, it's really hard. So I've made very small changes when I redo my body composition that really, despite how much I think I've been really trying, right? It just proves that at midlife, it is hard to maintain and make these changes, and that there clearly is a genetic predisposition to this as
Right.
well, right?
Right.
But for you, back to your point, I mean, you're 41, you're young, but you should be paying attention to it. And it is something that, like, I do believe, back to the blood pressure monitoring and the glucose monitoring, that having a body comp done once a year, and there's actually some really interesting apps. You can do them from the privacy of your own bathroom too. It's very interesting using AI. It takes pictures of you and you put in your height and your weight, and it's pretty accurate. I mean, again, like anything, the gold standard is a body composition done on a DEXA, but there's lots of other ways to get it and really good scales that we have in our office now. But I think that is helpful information so that you can track
Absolutely.
like anything else, right? Like you can
Yeah,
see what's happening
exactly.
over the next year or two as you're starting
And
to
I
become early
think
perimenopausal.
that is the thing that I hear from my patients. And I think also, I mean, it resonates with me too, is that like people, they don't want to have to track, but unfortunately, this time of our lives, we have to, right? We don't get to just kind of like eat whatever you want and not think about it. Like, this is the time that if we want to be healthy in our later years, this is when we have to think about it.
Yes, 100% agree.
Yeah, I know this conversation is making me want to just go lift some weights, go for a jog. But I want to start talking a little bit about women who are listening who are older, because I see these women in my office that are in their mid 60s, even early 60s, really, and they ask me, did they miss the boat? And what do they do now? Did they miss the boat on even getting hormone therapy? Did they miss the boat on being as aggressive? They're starting to learn how to lift weights for the first time and strength train for the first time. Like, what do you tell women in those situations?
Yeah. So, I mean, and I'm seeing this day in and day out now. So, we both know that the really exciting thing that's happening is that social media and lots of celebrities who have become, perimenopausal and menopausal now, and with social media, and lots of our physician colleagues who have very loud microphones on social media have really done a great job of elevating the conversation about menopause and hormone therapy and healthy aging and what we should be doing. And I think this has been overall really, really positive for all of us in the space, right? We were just at our Menopause Society meeting, and just the exponential growth in the organization. And there's like some really, really, really sea change positive things happening. But with that, there's also some, in my opinion, misinformation that's being disseminated out there. And some of that misinformation has generated a lot of fear among women, right? So exactly the group of women that you're talking about. So these are women who, for the last 15 years, have been told, despite not in my practice, because I've been really a hormone advocate even since the WHI and doing a lot of prescribing, right? But I'm one little small person in this, world of very negative messaging for the last years about the risks of hormone therapy. So the majority of women we know have not been offered or have taken hormone therapy. So now they're 65, they're hearing a different message on social media about the potential benefits of hormone therapy for bone, brain, heart health, sexual function, sleep. I mean, there's lots of messaging out there. I mean, the one that I hear a lot now is thinking about hormone therapy as a longevity medication, right? Which is a whole different discussion. But with this, if we focus on heart disease, right? The women that are coming in that are 65 now and they're like, shoot, have I missed the boat? And I can tell you what I do in practice. And this is why you and I both know that menopause medicine and doing it well is not a 5-minute visit and does really require individualized, personalized, it's pretty time consuming care, because what I do is really want to assess all of these domains of health of where that woman is today, right? And when we're focused on cardiovascular disease, if she's postmenopausal for 15 years now, the guidelines that we use in our world are within 10 years from their final menstrual period and under age 60. So now I have a 65-year-old woman who's 15 years from her last menstrual period, who's not within that 10-year period of time, and she's asking about hormones. So the first thing is, the question is, why is she asking about hormones? Like, is it because she's thinking of it now as a longevity drug? Is she still having vasomotor symptoms or sexual dysfunction? Does she have osteopenia or osteoporosis that she's worried about? But it's going in and assessing all of these individual risk factors for her. So it's really looking first and foremost for me in this setting at her cardiovascular health. And so for me, it's starting again with the basics, right? What is her family history? Has she had any prior symptoms or events to suggest that she has already established cardiovascular disease? And then it's looking at all of her metabolic factors, her lipids, some novel lipid factors, markers now that we're doing. So LP little a, high sensitivity CRP, ApoB, and thinking about then whether or not we would do any additional evaluation on her. And so I am using pretty frequently in this setting what's called a coronary calcium score. Now, coronary calcium score is like any test we do in medicine. No test is perfect. It is another data point for me to evaluate this patient. So if this 65-year-old woman has perfect blood pressure, perfect blood sugar, perfect lipids, she's active and exercising and eating well, and has a coronary calcium score of 0 and is still having vasomotor symptoms, that is a patient that I would think we can go ahead and think about menopausal hormone therapy again for treating of vasomotor symptoms and for helping her bone health. Now, again, I didn't talk at all because it's a whole different discussion about assessing breast health and whether or not she's at high risk for that. And that would be a separate discussion. But if we're just thinking in cardiovascular assessment, that's how I would approach that patient. The flip side is I have a patient who, is overweight, has pre-diabetes, whose triglycerides are elevated, whose LP little a is elevated, whose LDL is elevated, who's got hypertension that's not treated, and who has a coronary calcium score of 15 or 30 or 90, that patient I'm thinking about differently, right? Because what we do know from the data is that we do clearly believe that once you have established plaque, you're starting already on this plaque formation, that estrogen may carry more risk. Now, with that said, does that mean I would never give that patient, right? And this is like kind of the data free
The shared
zone where
decision.
it's a
Yeah.
little bit of judgment. What I would
Yeah.
tell you is for me, it's fixing every single one of those things, fixing their pre-diabetes, getting this patient exercising, making sure that her blood pressure is well controlled, having her on a statin, having her on blood pressure medication, really doing all of those
Yeah.
things first. Right.
Optimizing her
And
health and
then
reducing her risks. Yeah.
maybe we're talking about depending on her symptoms and going forward, but it's nuanced in that setting. And those are
Absolutely.
different patients. And again,
And
and I would just say that's the
yeah.
third category of the patient is
Mhm.
now the patient who's been on menopausal hormone therapy for 15 years, who's now
Right.
65. What do we do with those patients? And that's a whole nother nuanced discussion as well.
Yeah.
Again, a person who's been on hormone therapy is different than a person who's been without hormone therapy for
Right.
15 years and we're starting, but they're just all very individualized discussions.
Yeah, absolutely. Thank you for that because I find it perplexing. And I do often have people do a cardiac calcium score because I tell them, yeah, we need more information. I at least need more information to make any recommendations. But I have women that I don't necessarily feel like the safest for them is to start on hormones. And I'm grateful that we have some good non hormonal options now
Yes,
because
yes, for
things
sure.
are better than they were 10 years ago, right? That's the other thing that people should know about that you probably are not going to go home with no options. There is
Right.
there's something to help you, but it definitely is challenging. I have had patients come and ask me for hormone therapy who are in their older years, like 65, even 70, and they're not necessarily symptomatic, but they're asking if they should be on them anyway.
Right. And I think sometimes those patients for me are coming in because of messaging out there now really about
Right.
Alzheimer's prevention. And I think,
Oh, yeah.
Dr.
Yeah.
Pauline Mackey really, I think, did a really good review of the
Yeah.
total body of the data there. And really, again, I think in women who are older, where they've been without hormones for a number of years, right? The data does not suggest prevention, and we should not be conflating kind of that messaging with patients. I'm very cautious about that. And that's what, the 70-year-old woman who shows up in my office is worried about, right? And I'm certainly seeing that there are some places. In fact, I have one patient right now who was started on hormone therapy actually through a virtual platform specifically for Alzheimer's prevention. She carries the genetic mutation and has markers. And again, and I think that's not the right approach, but she was given that by someone else. And I'm kind of working with her about that. But
Yeah.
there
Yeah.
is that messaging out there, which is concerning to me.
Yeah, definitely. And, it also kind of just brings us back to like, we need more data. We need more research. Like, I'm hoping that we
Yeah.
see more research come up in these areas.
I mean, you're going to be the one to carry the torch here with that. So I have to say, right?
It's a
So
lot of choices.
I'm at
A
the
lot of
end, very end, probably of my career in the next 5 years or so, and
choices.
I'm so profoundly worried about what's happening in terms of funding for all research and what's happening through all of our healthcare organizations in so many ways. And I hope that we do get the research because, again, it seems right now like we are flying by the seat of our pants in a lot of areas, and we're continuing to do things wrong because we don't have the data that we really need to make good decisions.
Right. Exactly. Like we know that there's been a disservice to women for the last hundred
Yes.
years plus, right? But we do not want to create more disservices to
Well,
women.
right. And I actually worry that that's happening, to be
Yeah,
totally transparent with you, right?
yeah,
Which is
yeah.
the absence of data. Remember, I mean, there were, centuries ago, we were doing a lot of things to human beings without data that were not right and harmful. And I don't want to see us go back to ignoring research and science and doing things, shooting by the seat of our pants and doing things to women and men that don't have any data. And I see that happening now. We are selling, promoting, marketing a lot of things to women and men out there without adequate data. And I think that's a very slippery slope and makes me very concerned about the future. I mean, again, in the breast space, I'm seeing, just obviously finished Breast Cancer Awareness Month and Menopause Awareness Month. And there's just been a lot of misinformation out there that really, really makes me very sad.
Yeah. Yeah. Well, I appreciate seeing you out there in the social media spaces, also giving good information. And I've seen that you've been brought on the news shows in Cincinnati to kind of talk about the correct information where we do have evidence. So I appreciate that advocacy work that you're doing. So, okay, to kind of bring things home and make things practical for people, if they don't have a primary care physician,
Yeah.
if they're like me and they're just non compliant, or they just like, the primary care physician is open from, I don't know, 9 to 3, and that just does
I
not
know.
doesn't work.
I
What,
know.
like what should people be doing? How can we get
I
through this in
know.
our, I mean, our,
You're asking the $1 million question, the billion, the $1 trillion question for our US health system, which is so profoundly broken right now in terms of how we are delivering care, that I don't have a great solution. Because although, menopause now, I mean, for the last, 30 years, I've been doing menopausal medicine, certainly, as Steve Goldstein says too, right? You say that you're a menopause doctor, it clears the room. Nobody's interested right now. For the last little while, people are more interested, right?
yeah,
Because of all the menopause having a moment. But this is really a problem. I mean, fragmentation, women's health does not just fall in the hands of OBGYNs or primary care doctors, right? And I have said for my entire career, the best care of women happens when people like you and I, OBGYNs and primary care, which is why I love the Menopause Society so much. It's multidisciplinary, where we are collaborating, communicating about longitudinal care across midlife and the lifespan, because that's what we have to be doing. Now, the problem is that's a perfect world, and that doesn't exist in very many places right now. And even one of the things that I have been really pushing hard at is, and you probably know this, with Epic and Athena and the electronic health record platforms, right? OBGYNs have one template that they use for their well women exams. And there's the Medicare wellness visit for primary care that looks different, right? Like, the templates are different. And for someone like me who integrates across both, who needs reproductive health and who's trying to do midlife, like, the templates don't even exist to provide the kind of care that we're talking about, which is such a barrier. And then you have just lack of access, like you said, to primary care doctors. And then even with primary care doctors, that there's such a dearth of them that have any knowledge or experience in menopausal hormone therapy and kind of midlife menopause care, because we haven't trained them for the last 20 years. And so there's so many problems at access that you're right. I don't have the solution. I mean, one of the reasons you're doing what you're doing, and one of the reasons that I'm doing what I'm doing, is because one of the ways I do believe that I can help positively empower women is through social media platforms and these kind of things, right? Trying to get the word out and doing the education stuff that you and I are both very passionate about and trying to do, because I think helping women understand that they need to be their best advocate because the system is failing them right now, and trying to get them that even if they're busy, to make time to get that doctor's visit and find that primary care doctor, like, that's the beginning, the first step. But I understand that the system does not make it easy right now for good primary care.
But you have created something incredible through Ms. Medicine, and maybe you can share with our listeners sort of what you've been doing around the whole country. And like,
I've been
it's
trying. I mean,
amazing.
right? So
It's
yeah,
amazing,
thank you.
honestly.
So, I have a practice in Cincinnati that I have 11 partner physicians and we provide care. That's where I see my patients. And then Ms. Medicine is a network that I've been working to build with other primary care and gynecology clinicians who want to be in this menopause space, kind of forming this network where, so Ms. Medicine is kind of our link between all of these clinicians across all of these other states, trying to support them in practice with some helping them with technology and billing and all of that kind of stuff, but helping them build a practice kind of like what I have in Cincinnati. And then Her Medicine is my education nonprofit and my passion project for both kind of trying to get education to internists in primary care and OBGYNs, the evidence-based stuff. And what I hope is in 2026 that becomes again a place where we can be collaborative among voices, because there are areas where some of us in the space who are clearly experts, where we don't agree on every single detail. We agree on the vast majority of things when it comes to midlife women's health, but there's specific areas where I wish that we could kind of find some middle ground. So I hope that Her Medicine will do that, and then trying to get the word out to women as well through.
Yeah, I mean, you're doing the things and training more people and
Remember,
bringing us the updated information. So I think it's amazing. And if you are someone listening and you're looking for a healthcare provider, then I mean, especially in Cincinnati, obviously you can see Dr. Larkin's
But
practice.
no, but right on the hermedicine.org, there's a find a provider. Certainly you can go to Ms. Medicine and see if there's a Ms. Medicine provider in your area as well. But again, we're small, we're growing, love to connect. So,
well, thank you so much for sharing your expertise and motivating us. I'm going to go work out. I'm going to do my blood work and work out.
Do your blood work. We'll come back and have a conversation and review.
Exactly. Thank you so much for your time. I really appreciate it.